It's my great pleasure and honor to join with this webinar program organized by the World University for Pediatric and Congenital Heart Surgery. First of all, let me apologize that I cannot finish it off all this topic within a limited time, but I advise you to take the screenshot and learn later. I greet you, for all of you, from Indian Society of Kawasaki Disease and Indian Foundation of Kawasaki Disease. You cannot forget this great legend of Dr. Tomisako Kawasaki. I met him in 2018. That was my last meeting with him, and it was in 12th ICADS held at Yokohama. He published 50 cases of previously known as acute febrile mucocutaneous lymph node syndrome. That was in a Japanese journal in 1967. Some of the legends you cannot forget. Professor Tsumoto Saji, he did the first PTCR in 1985, and he was the organizing chairperson for this 10th ICADS, but now he passed away. Dr. Kato is one of the eminent researcher in Kawasaki disease, and he also in the heaven now. Professor Naoye, in 1972, he did the first pathological study of Kawasaki disease. That is the reason I am showing this slide. And this was the Kawasaki Foundation. We started in 2010, and it is inaugurated by my mentor, Professor Hangji Lu. He is the father of the pediatric cardiology in Taiwan. And we did a wonderful, the puzzle cube, we made it as a health education cube. It has got 8 faces, and it will give all the information on Kawasaki disease. And within a few minutes, you can learn Kawasaki disease. 2018, we started the KD Society. And what is Kawasaki disease? It's an acute self-limiting systemic vasculitis syndrome. And last 55 years, no one knows the real etiology. That is the reason I written that etiology remains unclear. But definitely, this is affecting only the people with a substantial genetic contribution, and that susceptibility is the reason to get some children get Kawasaki disease. It is possible in infectious agents. It can be triggering agent. I say triggering agent, infectious, viral, bacterial, rickettsial, or fungal, whatever the etiology behind that. I also proved through my animal model. I did the first animal model in swine that this is an immune complex vasculitis. The staph and streptococcus also suspected to produce superantigen, and it can produce the circulating immune complexes and producing Kawasaki disease. The SARS-CoV-2 during the pandemic time, you know, many children with Kawasaki-like illness, many turned to criteria was really fulfilled for Kawasaki disease. Even though it is unclear, we know that is the RNA virus causing in SARS-CoV-2, producing Kawasaki disease as a triggering agent. So once the criteria is fulfilled, you have to treat as Kawasaki disease. This is an 18-year-old girl, came with a fever and irritability, day 4, maculopapular rash, and admitted on 5th, and day 7, the periangual peeling. I know that your diagnosis is nothing but typical Kawasaki disease. And once we know that the ASO, if it is positive, of course, we have to consider scarlet fever. But that is the reason I am showing this slide. Our ward nurse have a habit on recording on this handwritten paper, and it is very nicely recorded that the rising tendency in the platelet count, thrombocytosis is. But in this case, I say that abnormally ASO is high, elevated, even 8,000 cases, some people I seen. So I consider this is not a scarlet fever. Once the criteria is fulfilled, you have to treat as Kawasaki disease. The only etiology is known as a superantigen produced by streptococcus, and finally circulating immune complex producing and damaging the endothelium. What is superantigen? It is a bacterial or viral origin It's an unconventional protein, leads to massive T cell activation, lead to cytokine production. Even dengue fever in the later time of the disease progressing, Kawasaki-like illness, we have a dictator model for IC vasculitis I produced in the animal house. That is injecting horse serum that can produce type 3 hypersensitive reaction, and only the horse serum can produce immune vasculitis. So you can see, make out all the rashes, and even the proximal portion of the LAD was dilated. Even you can do the coronary angiogram. And the histopathology I did in the animal model of the coronary artery of the swine, we can make out the intimal thickening, and later stage smooth muscle proliferation vertically growing into the intima and smooth muscle proliferation. This is the patchy area of fibrosis and consolidation, and this is the intimal thickening alone. This wavy layer is the endothelium, and this is the smooth muscle, and this is the intramural coronary artery showing the intimal thickening and thrombus you can make out. The AHI diagnostic criteria, as you know, this fever plus 4/5 is principal criteria. That is definitely, it is a complete KD, and incomplete KD is fever plus 3/5 in principal principal criteria. The Japanese coronary, the circulation society, the criteria is almost similar, but included the fever. So that is complete Kawasaki disease means 5/6, and incomplete is 4/6. This is the important striking signs in KD: irritability with fever, unilateral lymphadenopathy. Of course, very rarely you can see bilateral, but always I say unilateral lymphadenopathy. A child fever lasting more than 7 days with irritability, you should suspect KD. And periangual notify that not the entire palm. Entire palm is scarlet fever. The periangual typical tip of the fingers, 10 days of the within 10 days of acute phase of the fever. That is what we see in India. In the outside countries, maybe even at the late second week or third week, this periangual peeling you can see. Erythema around the BC scar is typical clue to diagnose Kawasaki. This is the 63%. You can see this orange brown chromonychia. But after 1 to 2 months, if it is a missed KD, when a child comes to your OPD, if you seeing a transverse groove, you have to see for the coronary artery. If it is dilated, please start on aspirin. This is the typical Bu's line. And development of coronary artery is one of the most detrimental sequelae of the KD. And if it is untreated, 23 to 25% coronary artery can be involved. Even though it is a small and medium vessel disease, even it can occur arch of aorta, large vessel also. So you should be very careful, even examining from head to toe, even the axillary area. If pulsatile mass is present, this is an axillary artery aneurysm. We can make out that the vessels. This is the proximal LAD, and proximal the portion of the LAD, you can make it as a fusiform aneurysm. Here, the common location of aneurysm in patients with the KD in decreasing order I have mentioned. That the posterior descending artery, sometimes between the marginal artery, you can see this coronary artery aneurysm. If it is an inexperienced people, those who are doing coronary echo, you may miss this. This is the anatomic correlation of the apical four-chamber view. And the same anatomical picture, I am showing the RCA and the left main. And here, this is the coronary sinus. That means the posterior wall I am projecting. So this is the aneurysm, exactly what I am showing between the marginal and the PDA. This is the slide I am showing the C-score classification and timing of coronary artery echo. I don't want to describe. Please take a screenshot and learn later. And I want to explain what is sacral and what is fusiform. Fusiform is simple, gradual proximal and tapering. Sacral is equal axial and lateral diameters. Ectasia is simple dilatation. This is the AHI special criteria. Sometimes fever lasting for more than 5 to 7 days, and other criteria, if it is not fulfilled, you can consider this yet a special criteria to diagnose Kawasaki disease and treat as early as possible. This is the lab investigation I prefer, and all the lab investigation I written, please take a screenshot, you can learn later. And now, because of the pandemic time of the COVID-19, the SARS-CoV-2, you have to do RT-PCR and COVID antibody. When to refer for coronary echo? As soon as you admit the diagnosis suspect of KD, because we want to get a baseline echo. The line of treatment is, of course, intravenous immunoglobulin is the gold standard therapy with the salicylic acid. 2 gram per kg body weight over a period of 12 to 14 hours. Aspirin, we give 60 milligram. That is the consensus from the Indian Society of Kawasaki disease. Even 30 milligram also can work out as per the Japanese study. So if coronary artery is dilated with the ectasia, you continue till the aspirin, they continue aspirin till the resolution of coronary artery lesion seen. Coronary artery lesion with the aneurysm, of course, clopidogrel has to be added. Coronary artery lesion with the giant aneurysm, warfarin you have to add. That is, you keep the INR standard ratio 1.8 to 2.4. It is a lifetime therapy. Remember, if it is more than 10 C-score or more than 8 mm, it is a giant aneurysm. It will never regress. 1% of aneurysm will be giant aneurysm. It will never regress. It is a lifetime therapy. You have to start on low molecular weight heparin. I always prefer with sucralfate, and infliximab is the drug of choice as a first line if it is a resistant KD. After 3 days, if the fever is recurring, you consider as a resistant KD, and you have to give second dose of the infliximab or second dose of IVIG or with the methylprednisolone pulse therapy. Normal aneurysm classification by C-score I have showed you, and this is the example of giant aneurysm. And in that case, you have to give low molecular weight heparin. What are the cardiac consequences and natural history we saw? That is vasculitis, myocarditis, heart failure, valvulitis, and coronary ectasia and coronary aneurysm. Late cardiac complication, thrombosis, myocardial infarction, calcification, and premature calcification, and the myocardial infarction. Severe long-term complication can occur, mainly the coronary artery stenosis, the smooth muscle proliferation, migrate into edema, and produce myointimal proliferation. And long-term follow-up studies by Kato, I showed him, now he passed away, as per his study, 12% calcification can occur in 5 years, almost 44% by 10 years, 94% at 20 years of follow KD. And this is the natural history of coronary artery lesion. The intimal thickening and transient dilatation can occur, and but it will almost 90% will resolve by 60 or 90 days of time. But once aneurysm occur, 50% can persist, and 50% will resolve by 2 years of age. And later, some of the another 10 to 20% can resolve by 10 years of time. So the fate of coronary aneurysm, regression, localized stenosis, occlusion, and segmental stenosis, braid-like lesion, bridging vessels. This is giving hope for KVD children from your bottom of heart will definitely rejuvenate the children's heart and their life. Even though the drugs are threatening death in front of us, you treat your KD children as your own child. Thank you. Thank you so much. This is the website of Indian Society of Kawasaki. This is from the bottom of heart. Once again, I thank you. Thanks for this opportunity for giving this talk. Thank you.